This presentation is on human menopausal gonadotropins, a medication used in fertility medicine. I'm going to be discussing what they are exactly, the indications for their use, their preparations and dose, their treatment protocol, and any possible complications. So what are gonadotropins? So gonadotropins are a group of hormones which cause the development of sexual characteristics in men and women and also regulate reproductive processes in men and women. They include FSH, LH, and HCG. So despite their name, they're not produced in the gonads. FSH and LH are released from the pituitary gland, and HCG is primarily produced by the placenta. Smaller amounts are also released by the pituitary, liver, and colon. In terms of how they're released, the pituitary gland responds to GnRH, which is gonadotropin releasing hormone, which is released from the hypothalamus, and this forms something called the hypothalamus pituitary axis. So what are their indications? In other words, how can we use them in fertility medicine? So the exogenous administration of gonadotropins allows us to control the stimulation of follicle development and ovulation. Essentially, it allows us to induce ovulation in women who can't ovulate by themselves in order to maximize their chances of pregnancy. So in terms of ovulation induction, it's the first line treatment for women with hypothalamic amenorrhea. So this is when you have amenorrhea due to low levels of FSH, LH, and estrogen. The first line treatment for women with non-hypothalamic amenorrhea, such as PCOS or PCOS, is clomiphene citrate. The brand name for that is Clomid. However, for women who fail to ovulate on clomiphene citrate, they can also be offered gonadotropins as a second line treatment. Now, the difference, just a small little bit of knowledge about the difference between hypothalamic amenorrhea and non-hypothalamic amenorrhea is that hypothalamic amenorrhea is when you've got the low levels of those hormones, like I mentioned, and it can be due to things like stress, intense exercise, and disorderly eating, and women in general who have low body weight. Whereas non-hypothalamic amenorrhea is when you have normal levels of hormones, but it's due to other causes, things like PCOS, when you have a bit of insulin resistance, high levels of testosterone, cortisol, etc. As well as ovulation induction, it's also useful in ART, which is assisted reproductive technology, such as IVF. So we use drugs like gonadotropins to induce ovulation in women, to produce lots of healthy eggs for egg retrieval, which would be then combined with sperm to produce embryos, which can then be implanted into the lady's uterus. So what exactly are human menopausal gonadotropins? So they're a purified preparation of gonadotropins extracted from the urine of postmenopausal women. And it's basically LH and FSH in a 1-to-1 ratio. So it's administered by daily subcutaneous injection or intramuscular injection. The recommended starting dose is 150 IU for the first 5 days of treatment. And then after this, you have an individualized dose based on each lady's individual ovarian response. And the max dose is 450 IU. So your individualized dose will be anywhere between 150 and 450 IU. The treatment duration is around 12 to 30 days, again, depending on the lady's personal ovarian response. Patients pre-treated with GnRH agonists have a starting dose of 225 IU. And the brand name for HMG is usually Menopur. As you can see an image there, Menopur 75 IU. Ovulation induction in general follows quite a strict protocol. And the same goes for ovulation induction using HMG. So serial estrogen measurements and ultrasound are required during each treatment cycle to monitor the lady's personal ovarian response to therapy. So first of all, the HMG is administered daily until the serum estrogen level is more than 100. This usually takes around 7 to 12 days. After this, an individualized dose of HMG is continued, and ultrasound is used to document the number of follicles and their size. During this phase, this is usually called the active phase, and during this phase, estrogen levels rise rapidly, and follicles typically enlarge by 2 to 3 millimeters per day. Once the follicles are 16 to 20 millimeters in diameter, which is tracked by using serial ultrasound scans, a single dose of 5,000 to 10,000 IU of HCG is administered by IM injection, and this is to substitute for the endogenous LH surge, which triggers ovulation and the release of the egg. At this point, regular sexual intercourse is advised to obviously maximize the chance of pregnancy. 7 days after the HCG injection, we measure serum progesterone to confirm that ovulation has taken place. And then patients are advised an approximate date to expect a period, which is around 2 weeks after the predicted time of ovulation. Obviously, we don't want a period to occur because that means that there's a chance of pregnancy. So if no period occurs, then they should carry out a pregnancy test at home with an early morning urine sample. So just a quick question. What do you think is the success rate of ovulation induction by HMG? Volunteer answers, and the answer will be on the next slide. So just to preface this answer, this statistic is specifically looking at the success rate of HMG used for ovulation induction in hypothalamic amenorrhea. So it's not reflecting the success rate of assisted reproductive technology, things like IVF. It's only specifically for ovulation induction. So the chance of conception in each cycle is 15 to 20%, and 90% of women aged less than or equal to 35 will conceive within 6 treatment cycles, which I think are quite good odds. Finally, I'm going to discuss the complications associated with taking human menopausal gonadotropins. So there's an increased risk of multiple pregnancy, which includes twins, triplets, quadruplets, etc. There's also an increased risk of ectopic pregnancy. One of the more common side effects as well is ovarian hyperstimulation syndrome, OHSS. Now, this usually occurs 2 weeks after the end of treatment, peaking 7 to 10 days post-ovulation. If no pregnancy occurs, it resolves with your next menstrual cycle. If pregnancy does occur, then symptoms may persist for weeks. And the next slide is going to go in a little bit more detail about OHSS. So what is ovarian hyperstimulation syndrome? It's basically what it says on the tin. The ovaries become hyperstimulated, which results in ovarian enlargement and heightened estrogen levels. Symptoms range from mild to severe. Most cases are mild and can just be monitored closely by a healthcare professional. However, there are some severe cases which require urgent hospital admission. Now, mild to moderate symptoms include things like pelvic discomfort, nausea and vomiting, abdominal distension, and weight gain. However, severe cases can result in things like pleural effusion, ascites, ovarian enlargement more than 12 centimeters, venous thromboembolic events, oliguria, and electrolyte imbalance. And to give a bit of background knowledge on why these things occur, one of the characteristics of OHSS is the release of vasoactive factors, and these cause a shift of fluid from the intravascular space to the third space due to increased capillary permeability. And also ovarian neoangiogenesis, which is the development of new blood vessels from pre-existing blood vessels. So basically the net cause of all of this is we get tissue edema, so a buildup of fluid in the tissues, which can cause things like ascites, pleural effusion, compartment syndrome. It also leads to hypovolemia, which leads to things like decreased organ perfusion, which can cause things like liver or renal failure. And fluid shift from the intravascular space to the surrounding tissues also causes hemoconcentration, so the blood becomes quite concentrated, and hypercoagulability, which results in things like the venous thromboembolic events. So that's why severe cases can't be managed by the GP or by your fertility specialist. You need to go into the hospital for urgent admission. And there are also some really rare serious events that can occur, including ovarian rupture with hemorrhage and respiratory distress, again, all of which need to be managed in hospital. That brings me to the end of my presentation. Thank you for listening, and I hope that helped. I've got a link here for Teach Me Obs and Gynae, an introduction to infertility. This is a really good link, in my opinion, for anyone who's interested in reading a bit more about infertility, what some of the causes are, and common treatments on offer. As well as if you'd like to leave me some feedback, that would be much appreciated. You can scan the QR code that's on the screen. And yeah, thank you very much. I hope this helped.